Tetralogy of Fallot, TOF, is a congenital heart defect that affects thousands of infants worldwide. TOF is a complex condition characterized by a combination of 4 cardiac abnormalities. This video aims to provide an educational overview of Tetralogy of Fallot, exploring its causes, symptoms, diagnosis, and treatment options. Patients with Tetralogy of Fallot experience early cyanosis as a result of a right-to-left shunt. The severity of cyanosis depends on the degree of stenosis, which directly influences the extent of shunting. In response to cyanotic spells, patients have learned to squat, a maneuver that increases arterial resistance. By doing so, they can decrease shunting and facilitate more blood flow to reach the lungs, providing some relief from the cyanotic episodes. Additionally, a characteristic boot-shaped heart appearance can be observed on X-rays, indicating the impact of right ventricular hypertrophy in this complex congenital heart condition. An easy way to remember Tetralogy of Fallot is by using the acronym PROVE, which stands for the 4 main components of the condition. P. Pulmonary stenosis. R. Right ventricular hypertrophy. O. Overriding aorta, which is an aorta that overrides the VSD. V. Ventricular septal defect. 1. Understanding Tetralogy of Fallot. Tetralogy of Fallot is a congenital heart defect that involves 4 specific malformations in the heart. A. Ventricular septal defect, VSD. This is a hole in the septum, the wall that separates the heart's 2 ventricles, allowing blood to flow between them. B. Pulmonary stenosis. It is a narrowing of the pulmonary valve or the blood vessels that carry blood from the heart to the lungs, restricting blood flow to the lungs. C. Right ventricular hypertrophy. Due to the increased workload caused by pulmonary stenosis, the right ventricle becomes enlarged and thicker. D. Overriding aorta. The aorta, the main artery that carries oxygenated blood to the body, is displaced and straddles both the left and right ventricles, receiving blood from both. 2. Causes and risk factors. The exact cause of Tetralogy of Fallot is often unknown, but several factors can contribute to its development. A. Genetic factors. In some cases, TOF can be linked to genetic mutations or chromosomal abnormalities. B. Environmental factors. Certain maternal conditions, such as poorly controlled diabetes or exposure to certain medications or chemicals during pregnancy, may increase the risk of TOF in the unborn child. C. Family history. If a parent has a congenital heart defect or TOF, there is an increased likelihood of the condition occurring in their offspring. 3. Symptoms. Symptoms of Tetralogy of Fallot may vary depending on the severity of the malformations. Common signs include A. Cyanosis, often referred to as blue baby syndrome. Cyanosis occurs due to the mixing of oxygen-poor blood with oxygen-rich blood, leading to a bluish discoloration of the skin, lips, and nail beds. B. Difficulty breathing. Infants may experience shortness of breath, rapid breathing, or have trouble feeding. C. Clubbing. In severe cases, the fingers and toes may develop a rounded, club-like appearance. D. Fainting spells. Older children may experience fainting episodes or dizziness. E. TET spells. TET spells, also known as cyanotic spells or hypercyanotic spells, are critical episodes that can occur in individuals with Tetralogy of Fallot and other cyanotic heart defects. These spells are characterized by sudden and severe exacerbation of cyanosis, bluish discoloration of the skin and mucous membranes, due to decreased pulmonary blood flow and increased right-to-left shunting of deoxygenated blood. TET spells are typically triggered by factors that reduce systemic vascular resistance, such as crying, feeding, or physical exertion, leading to increased blood flow through the right-to-left shunt. During a TET spell, affected individuals may experience extreme difficulty breathing, become agitated, and exhibit signs of respiratory distress. These episodes can be life-threatening if not promptly managed. Immediate intervention, often involving the knee to chest position or administration of supplemental oxygen, is essential to alleviate the cyanosis and increase pulmonary blood flow, thereby mitigating the severity of the TET spell and preventing potential complications. Regular follow-up care and close monitoring are vital to managing Tetralogy of Fallot and minimizing the occurrence of these critical events. 4. Diagnosis. Tetralogy of Fallot is usually diagnosed shortly after birth or during infancy. Diagnostic methods may include A. Physical examination. The characteristic blue coloration and heart murmurs may be detected during a physical examination. B. Echocardiography. This non-invasive imaging technique allows healthcare providers to visualize the heart structure and identify the specific abnormalities. C. Electrocardiogram, ECG, EKG and ECG records the heart's electrical activity and can reveal abnormalities associated with TOF. D. X-ray, boot-shaped heart on X-ray. 5. Treatment. The treatment of tetralogy of Fallot aims to improve the child's quality of life and correct the heart defects. Options may include: A. Surgical repair. Open heart surgery is the primary treatment for TOF. The procedure involves closing the ventricular septal defect and relieving the pulmonary stenosis. B. Palliative procedures. In some cases, a temporary surgical shunt may be placed to increase blood flow to the lungs until the child is older and can undergo complete repair. C. Medications. Medications may be prescribed to manage symptoms and improve heart function before or after surgery. Conclusion. Tetralogy of Fallot, TOF, stands as the leading cause of cyanotic congenital heart disease, accounting for approximately 5% of all congenital cardiac malformations. The syndrome encompasses 4 cardinal features, namely, a ventricular septal defect, VSD, right ventricular outflow tract obstruction, subpulmonic stenosis, overriding of the VSD by the aorta, and right ventricular hypertrophy. The heart's appearance is altered due to right ventricular hypertrophy, leading to an enlarged and boot-shaped configuration. This enlargement affects the proximal aorta, causing dilation, while the pulmonary trunk undergoes hyperplasia. The left-sided cardiac chambers retain their normal size, but the right ventricular wall exhibits marked hypertrophy, occasionally surpassing the thickness of the left ventricle. The VSD typically appears large and is located close to the membranous portion of the interventricular septum, with the aortic valve directly overlying it, overriding aorta, serving as the primary outlet for blood flow from both ventricles. The obstruction of the right ventricular outflow is commonly due to infundibular narrowing, subpulmonic stenosis, although it can also result from pulmonary valve stenosis or complete atresia of the valve and the proximal pulmonary arteries. In such instances, the blood-soul pathway to the lungs relies on a persistent PDA or dilated bronchial arteries. Clinical features. The clinical presentation of tetralogy of Fallot is influenced by the hemodynamic consequences of right-to-left shunting, diminished pulmonary blood flow, and increased aortic volumes. The severity of the condition primarily hinges on the degree of the pulmonary outflow obstruction. In some cases, even without treatment, patients can survive into adulthood if the pulmonic obstruction is mild, mimicking an isolated VSD wherein the high left-sided pressure only causes a left-to-right shunt without cyanosis. However, more severe degrees of pulmonic stenosis often result in early cyanosis. As the child grows and the heart enlarges, the pulmonic orifice fails to expand proportionately, leading to progressive aggravation of the stenosis. Fortunately, the pulmonic outflow stenosis protects the pulmonary vasculature from pressure and volume overloads, preventing the development of pulmonary hypertension and making right ventricular failure a rare occurrence. Nonetheless, patients experience typical sequelae of cyanotic heart disease, such as hypertrophic osteoarthropathy and polycythemia due to hypoxia, resulting in increased blood viscosity. Additionally, right-to-left shunting increases the risk of infective endocarditis and systemic embolization. Complete surgical repair is achievable for classic tetralogy of Fallot, but it becomes more complicated when pulmonary atresia is present. In conclusion, tetralogy of Fallot manifests as a complex congenital heart condition involving 4 primary features. Understanding its pathophysiology and clinical implications is crucial for timely diagnosis and appropriate management to enhance the patient's overall prognosis and quality of life.